This is an individual who feels like she's getting a click right in that groin area where she's pointing as she's moving her foot outward. Now, when we're looking at hip range of motion, the structures of the hip cross the knee and they cross the pelvis. Now, what most people only think of motion at the hip, but there's really motion that needs to occur at the pelvis on that particular side. I go through this in the Correct Exercise program, Total Body Renovation, when I talk about the pelvis. The pelvis is one of the most undertreated areas of the human body because it's so important to hip range of motion. For most people, their hips move just fine. So for this individual, she is feeling a click, and it's typically at end range of motion, which is what she's showing me right now. She's got good external rotation. It's moving, it's moving, it's moving, and it's actually kind of stopping right here. And I'll show you that as I get her moving a little bit more. So where the dysfunction is, this is open chain. So we start at the foot, we go up through the knee, then up to the hip, and then it stops right here. And then there's a compensation of rotation. So I'm going to show you what that looks like. So here's her moving. And again, slow, 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 right there. See how her belly moves? Right there. That's where her restriction is. She turns right there, okay? So her problem is like right where her palm is. Now again, is it here? Because most people would think, yes, that's where you need to lengthen. I venture to guess that her restricted, and I know this person and I know she works the connective tissue here quite a bit. It is and again, predisposing information. There's a muscle there called the iliacus. And when we're sitting, that iliacus is shortened. If we sit for a long period of time, the muscle fibers become adhered, and then we lose range of motion there. So she's been working her iliacus. I feel that it is posterior on this level. So deep in the glute is where I would encourage her to go ahead and palpate and again, release as needed. And then reassess whether you're getting that clicking in the heel. So as soon as you feel the click, then you would look in the mirror and see where you are in that range of motion. In the Correct Exercise program, I also tell you at what points in the range of motion are the responsibility of the femur, of the pelvis, and then even of the sacrum. There's movements that need to happen. So any of those structures might, not the hip, but the sacrum or the pelvis may be involved, or any of the connective tissues that are attached to that particular area. But that's where the dysfunction lies, because there was the compensation of movement on the side. All right, let's move on. So again, right there is where there's movement. Now, one other thing to note is that, see the wrinkles? There should be wrinkles all through here. So again, dollars to donuts, there's some restriction anterior or posterior at these levels right here that are not wrinkling, because we'll take a look at her other side in a moment. See, there's movement all the way to here and then nothing there. All right. So now she'll go ahead and show the figure skating pose. And again, what happens? It's good, it's good, it's good. It stops, and then it really stops. So again, this whole area really needs to be looked at. When we'll see the difference on the other side in just a moment. So she's going to demonstrate that. And she's actually even then correcting here. And notice how when she externally rotates that foot, she actually externally rotates her body. Right there. See how she's just moving at the abdomen? Turn. And it's not smooth or sequential. It is on the standing foot, but not on the non-standing foot. And again, no wrinkles there. Now let's look at, she's going to show us the other side. And we'll see a much smoother range of motion, smooth, 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 and notice the wrinkles, notice the non-rotation. So you can see the difference. So that's where this individual, I would say, needs to go ahead in and see and feel where that issue lies. Look at those beautiful wrinkles right there. Much easier for her to assume. And now we're going to look at, sorry again. Now we're going to look at somebody who has a knee problem. And what we're going to do is look at the motion over the foot as they're going back, up, they're compensating with the upper body, and now when they're coming forward, not much translation there, and even a movement in that position. So if we're looking at the right versus the left, we can kind of see a difference with regard to that. So now I'm going to go back just a little bit more. So as this person is coming forward, what we'll notice first is that they're compensating already because their right foot is externally rotated. When somebody has a foot that's externally rotated, 9 times out of 10, it's because they lack dorsiflexion, which means that their structures throughout this area here on the top of the foot do not move forward. The ankle is usually not an issue. So if we're moving forward, he moves, that looks okay. Now, what we'll look for here is maybe the heel lifting, a movement of the toe, turning the foot out a little bit more, up, but no, he moves his upper body. So if you see that, he comes back, up, back, shift forward, and then look, up. So when he's advancing himself with walking, he's going to be flexed forward, right? And putting more stress on his back because he doesn't get good translation there. Now let's look at the other side. So this is his left foot forward. And as he moves, he starts right away where he flexes his upper body because the lower leg is not moving or advancing forward at all. Let's continue to watch. Back to center. He's going to go back a little bit. And now coming forward. And he stops right about there. So looking at both feet and coming forward. Little translation on the right, really no movement on the left. And that is the motion for this person. Okay. Now we're going to look at me. So as I move, one of the things I will show you is that as I come back to center, if you'll notice my right knee and my right foot. So as I'm coming over to this side, hold on, as I move, stop. Right there, my knee will twist outward a bit. Very, very subtle. And the other thing that doesn't happen is that my arch does not collapse on my right foot. So notice my right foot. I come, the motion just stops right there. I get no motion through, I get no translation through that toe on the right foot. And so I am now increasing that pressure, right, in through this particular area. And then when I look at if you look at the other foot, when I do that same motion where I'm going to be going to the other side, see how I'm not moving there? Now look at that side. Much better where I'm moving through there, but this one, bang, right? It stops right there. on the left, it goes all the way through the toe. So I'm not putting weight through my right foot, my right big toe, which is the primary balancer in foot. And it is no mistake that I sustained a right knee injury. So now I really keep my right foot or my right toe grounded to help with that stabilization. Yep. The heel comes up just a smidge right about there. Now again, there's my dysfunction level. Is it posterior? One would think everybody stretches their gastroc, right? I can't tell you how many people have dysfunctions anteriorly, because what do we do a lot of times with our shins? We bang them, right? And that there's not a lot of tissue here and is not malleable. So it doesn't get massaged, it doesn't get released. But again, it could very well be that anterior area right in the lower leg. Then we need to get translation in through the ankle itself, then through the toes, through the midfoot and through the toes. As I'm moving backward, and now here's my other foot. This is my right foot. This is my injured foot, and we'll see when we come forward again. Right there, right about there. Again, stop. So I'm going to look at the lower leg. I've worked my foot quite a bit, looking at the lower leg, and then also see the angle or see the support underneath the knee of this lower leg. It's not there, but wouldn't it be nice if this lower leg came forward to really be able to continue to absorb forces through that knee joint? So again, a lot of people who have a hyperextended knee, because this lower leg is not coming forward, and there's some sort of restriction either in the lower leg or the foot that is preventing that. And this is what the diagnostic motion evaluation will show you, or when you tune in, you can feel it yourself. So again, these are motions that are very similar. I'm going to get into that for a second. They're very similar to Feldenkrais motions. In fact, I call them foot clocks. And the term clock was kind of coined by Moshe Feldenkrais when he looked at motion. So many of us are familiar with pelvic clocks. You can do this on any area of your body, and it will reveal where the difficulty lies. So you can do clocks with your shoulder blades, right? And you can feel where that area is. So again, you just think of a clock and move about it. You can do it on your back and move just the pelvis, or you can move the whole spine. I like to look at things in function because again, that is more telling to me from a corrective standpoint. I want, when people come see me, I want to get them out of pain, within minutes. So I really go to the particular area that they're having, or motion that they're having difficulty with. And then when I see it, it will tell me everything. So there's a story I tell about a tennis player, I'm about to show off a Nadal, who she kept falling on the tennis court, and she sustained two pretty severe injuries. One was a fractured pelvis, and the other was a fractured foot. When I did that side-to-side movement, right, because that is what is unique to tennis versus daily life. She didn't fall walking down the street. She fell on the tennis court. What's different? Side-to-side motion. Soon as she weight shifted over to one side, her foot, literally, as soon as she just went just like 1 degree over, the big toe came right off the ground. She lost her base of support right away. And sure enough, her dysfunction, again, it is in the closed chain. So we start higher up. The connective tissues that cross the foot go across the knee. We started right below the knee. I released it. She was better immediately. She never fell again. So it could be that simple and really, really, really powerful. So that is, why I'm sharing it. Okay. So there is, all right, good. All right. So when I'm going to look at now, I'm going to take a look at Rafa Nadal. So I did a whole video on this, and I might include it in the recording. And when I was watching him on screen, I was looking at his motion when he was setting up for his serve return. But even just looking at him here, what I'll notice is that, and I after I was watching it, I went and I had to find out. Rafa had a lot of knee problems, and I'm like, I bet you it's his left knee, bet you, because of this. So if you see, he's not bearing weight through the medial part of his foot as his leg is coming forward. So where is his stress? It's at his ankle and it's at his knee. And this knee is actually internally rotated. Why? To bring weight over his big toe. You need to bring weight over to the big toe for balance, and also to have good force control. So every compensation in the body is to bring the weight over the big toe for balance. It is our primary balance. Again, if you look at wrinkles, good wrinkles on this side, pretty good wrinkles here, no wrinkles there. And if you look at his shorts, same kind of thing. So there are pretty good wrinkles in through the clothing. So he has pretty good motion, but I would say he's probably restricted here because the wrinkles kind of are separate, as well as here. So again, it could be his IT band, which a lot of therapists say, oh, it must be the IT band. No, it could be in the groin, or it could be in the thigh, or it could be in the hamstring. We don't know. We just know the level. And perhaps, you know, when we're looking here, I would venture to guess his dysfunction is in that foot portion, the same area that I showed you on me that does not move, which is this area right here. And maybe his structure is like that picture with the girl who went on her tiptoes, where these bones right here are literally kind of deviated inward, as is the heel. So it'd be really interesting to look at Rafa's sneakers, as well as I would love the chance to evaluate him, but obviously a big fan. So rooting for him, and I will probably be watching tomorrow. It's interesting, if you don't know, he's in the middle of the French Open, and he was playing Novak Djokovic. Now Djokovic, I did a video on him because he actually loses his base of support. He falls a lot on the court, and it's probably, you know, he's not much taller than Nadal. He's not extremely tall, so it's not a center of gravity issue. But I do feel that he often slips. So when you're moving backwards, right, as I was showing forward and backward motion, when he's moving backwards, I believe that he probably doesn't have good translation of the structures of the lower leg posteriorly, so that he can maintain his toes on the ground. So when his lower leg goes back, he probably comes right off, and I think that's why he slipped. So what was interesting, I didn't watch him, but apparently his last match, he fell a couple times, or at least once. Last thing to talk about, which we talked about things not moving enough, and then other things moving too much. The illustration I like to use for that is like a chain, like in a necklace, right? It's actually called the kinetic chain. So if I'm wearing this necklace, right, and I have it kinked right here, but the necklace is moving constantly, right? If I'm not moving here, what is moving too much to make up for the motion? This length right here. And that's how I kind of equate that lack of motion. So when you have an injury or pain, so many people on here might have hallux rigidus, hallux limitus, which is too much movement or arthritis at the big toe joint right here. And this is the joint that's affected. This is the one that moves too much. Eventually, it starts to move too little because of that arthritis process and the inflammatory process, which also decreases range of motion. But what structures are right next to this joint? The proximal hallux joint, which I often find is usually not moving, right about here, and then also this metatarsal and the structures right above the metatarsals. These are the proximal row of tarsals. These three bones are oftentimes, look at how small the joint space is on x-ray. Many times you won't even see this bone on x-ray, okay, because they're so squished. Now, you might want to say, why does that happen? When you're in utero, your foot is actually in supination, so it's twisted in. When it's twisted in this position, these bones kind of come together. So after we're born, then we start crawling. Crawling, we're still oftentimes in supination, and then we go into standing. And immediately we pronate, which is normal. And then we start to develop the arch. In indigenous cultures and throughout history, we didn't wear shoes and we didn't walk on flat terrain. So when we did that, when we're climbing rocks or going on trees or, you know, whatever, things that really require balance, well, first, our intrinsic muscles of the foot really get very strong because those are our balancers. So that helps with mobility. But the other thing is that if I'm standing and I go over a rock or something like right here, I'm getting a mobilization. Okay, so that is something that winds up happening, especially when we're little, and we do tend to have good mobility in our forefoot as well. But what winds up happening now, we get put in shoes, we don't get movement here, and we walk on flat terrain. So that is one reason why these structures are so important to mobilize, and why they don't get mobilized adequately is because people put big balls underneath here. And you need to have a tiny releasing tool to get in between these joints. I use the tip of a pencil, the pencil eraser head, to get in between here, because then I can specifically get into those connective tissues. The smaller the releasing tool, the more specific, the superior the result. Now, many people, when they have pain from an itis, either hallux rigidus limitus, or if they've had surgery like a bunionectomy or any other kind of foot surgery, or if they have a tendonitis or osis, or a fracture, they get put into a boot. So again, you're purposely being immobilized, maybe for one joint in the foot, but you know how many joints you have? You have 33 joints in your foot. So you're getting mobilized for maybe 2, 3, maybe 3 at the most likely 1 or 2, okay, is all that needs to be immobile. Everything else can fully be mobilized from a safety standpoint, but again, that function. So we get put into these boots that restrict our range of motion, particularly what? Dorsiflexion. And then you come out of the boot and the doctor's like, oh, you should be better. You didn't even look at necessarily what motion was causing that hypermobility or that area that got torn or broken. So again, if things aren't moving, the thing that's going to get broke is the thing that is the weakest link. So this is the area of the ankle that's the most unstable. That's where all the ankle springs occur. 90% of ankle springs are here. Why? Because it's very, very vulnerable, right? This is very stable. Okay, stable things don't usually get hurt. This is very vulnerable. Okay, it's not very stable. It's being held together by ligaments and muscle. So it is very unstable. So what we need to do is we need to distribute the motion throughout the entire foot, all 33 joints, to offset the excessive motion maybe at the ankle joint. So I treated a skateboarder. He had a competition the next day, and he could barely walk, much less be on a skateboard. And all I did not move this at all. I stabilized this, but guess what? I mobilized, or I moved all of the joints prior to that area so that he got better translation. So then there wasn't so much motion right here, right? Because if there's not specific movement through here, where's it all going to go? Right there, right there, right there, right there, right there. So you really have to move through the kinetic chain for knee, for hip, for toes, foot, and ankle. And when you are immobilized and you come out of that immobilization, it is going to be essential that you mobilize the structures that were not affected. I don't ever, and I had to think, I don't ever mobilize something that is inflamed or injured, ever. I stabilize it. And I teach people in my programs to stabilize it with tape. You can stabilize it with your hands also. And that helps the mobility of the other areas. So again, really important to create motion through the entire system, except for the area that's moving too much. And how do you know? Pain. When you palpate, if it's tender, it needs to be released. And that is the simplest way to look at it. So you can feel it through motion. You can maybe see it through motion, particularly if you're a clinician or somebody who's tuned into your body. But if you have to guess, again, it's going to be the structures right near that particular area that is injured. So where the ankle is usually the fibula. Fibula is usually always in here. That's one of the least treated structures in the human body. The heel is definitely a player also. The talus, to get these things mobile so that you don't wind up with an injury like that. Because again, it's about prevention, and then it's certainly about after you've had an injury or a surgery, is making sure that the forces that cause that injury or need for surgery to happen are offset. So it's either absorption or it is a motion problem, and both of which can be addressed with release, specific release, as well as taping are your two strategies. So any other questions? I have a question coming up here. After you told me about shoes preventing our mobility in those small bones, I'm using my 5-finger shoes more often, and I can feel those bumps and keep the foot flexible. I'm getting stronger. Absolutely. So barefoot is best, not ideal, obviously. 5-finger toes are really good choices. They're minimalist. Now, they're not for every foot, because if you don't have an arch, you're not going to be able to absorb. And that's where shoes can come in handy. They can give you that absorptive quality with the sole of the shoe. But one could also argue that then you won't ever have an opportunity to develop those intrinsic muscles. So it is it's a tough situation, and it's case by case on which way to go with it. I usually test as far as function, which makes do shoes make it more functional, or does barefoot make it more functional? And if you can get away with barefoot, then be barefoot in the house. And then also there are specific exercises to do, and obviously improve alignment, which we'll get into the ways to improve alignment. Taping, but only after release. Now, orthotics. That is a controversial subject, because the orthotics do not address each specific joint in the foot, right? It's one device that's dealing with 33 joints. With a piece of tape, you can address each particular joint. When you're releasing, you can address each particular joint. So many times the orthotic will put you in a quote unquote more functional position, but at what cost? You're probably going to be compensating someplace else, and you're never going to address the problem. So you're going to be reliant on these things for the rest of your life. Why not fix the foot? Because you can either fix the foot or you can fix the surface the foot is on, which is either an orthotic or shoe. And the majority of conventional treatment is orthotics or shoes, which, by the way, are not shoes. Or you can, I prefer fixing the foot, and you can, except most individuals don't know how. They don't feel that it's possible, and it's not a way for them to, it might not be an incentive for them to maintain a business. So again, something that is important to consider is that what's in it for the person who's advising you if you get better, and what's in it for them if you don't. And for, unfortunately, many individuals, it's from a business standpoint, they make more money by you not getting better. So, you know, I don't like to think of people doing that. However, I've been getting some correspondence just today from clients and with visits to the podiatrist, and some of the things that they're saying are really off-putting. Somebody who doesn't even have pain, the doctor's considering surgery. That's just not a reason to have. The only reason to have surgery is because whatever's going on in your body has affected your quality of life, where it's affecting other things in the negative, and you're getting into that negative perpetual cycle. But that's one reason. But you have to earn, in my mind, you have to earn your right to have surgery, meaning that you've needed to exhaust every other option and done everything that you can to make yourself better, and then you can acquiesce to a surgical intervention. That's how I felt when I was giving birth to my daughter. I did not want to have a C-section. I did everything I could to prevent myself from having a C-section, but I knew going in that I had done everything that I could to prevent having a C-section. If I needed to have it, I was going to have it, and I would have been okay with it. There would have been no regrets in my mind. Thankfully, in spite of being injected with Pitocin, which oftentimes causes a C-section, I was able to give birth naturally. So there is a question. Yeah, so, okay, so somebody was totally dependent on orthotics for figure skates, and when she was fitted properly with a minimal tilt, much more controlled skating. Yeah, because again, then you have the ability to use those 33 other joints, and you're just addressing something more specifically. So in some ways, less is more. Less is really more. Okay. All right. So any other questions that have come up? You know, this is, again, this is something that I'm sharing with people because people are reaching out to me, and many people who are in my programs are having knee problems. So I really wanted to address this and kind of get them to tune in or consider reaching out to me. So if you're having a chronic issue and what you're doing is not being successful, just reach out to me, support@dlwalkerconsultant.com. You can send me pictures, you can send me videos, and I will give you an honest assessment of whether I can help you or not. Certainly in person or not. Somebody who reached out to me once, and she traveled several hours to come see me, she was describing what was going on with her, and I clear out said to her, I said, I'm not sure that I can help you. I'm very good at what I do. I'm going to try my best, but I can't say for certain. So I can give you a percentage of how certain I am that I can help, and it will be an honest one, because that's the way that I choose to practice. And so, you know, I'm not going to say to somebody that, you know, make them promises that I don't feel that I can live up to. But again, knowing this and using these techniques on that woman, I was able to do what I think 11 podiatrists, I don't know, 7 massage therapists, chiropractors, that no one else could have done. That is, you know, that's that. So go ahead and, like I said, reach out if you're having an issue that you're not, you know, you're really stumped on. The Diagnosit Motion Evaluation will likely reveal it. And if you send me a video, I can take a look and see if I can see it. Okay. All right. If there's no other questions, you can always reach out and contact me if something comes up afterwards, same email, and I will see you in the next live or the next training. So have a great night or morning wherever you are in the world, and I'll talk to you soon. Bye.